goes to the heart. Can we visualize the lymphatic channels? Yes, we can. There are many ways. For example, this one is the photoacoustic indosing in green with a special camera. You can see the lymphatic channel like that. And also the modalities that we have in the imaging department, like the conventional lymphangiography, lymphoscintigraphy, or MR lymphangiography with or without gadolinium. So the problem may start with the blockage, like the obstruction. When there is an obstruction of the lymphatic pathway, it's like the venous problem. It causes the congestion and reflux. So when it causes the reflux, the fluid will leak, maybe leak into the interstitial tissue, it causes the lymphedema, or maybe leak into the outer pathway that has opening. So it may cause a leakage also from the obstruction. So the treatment actually is, if we think about the arterial occlusive disease, you usually to open that occlusion, right? But it's difficult, very difficult with this technology to open up that kind of obstruction with this technology. So we usually seal the leakage with some kind of material instead. It's like the varicose vein and two blades with the varicose vein instead. So if the patient presents with the lymphatic leakage from the tear or injury, if it doesn't heal by itself, it causes the lymphatic leakage. So the treatment is straightforward. Try to embolize, like the bleeding. If there's a leakage, you just embolize that tear. And special condition in the lymphatic system is the congestion, especially for the heart. When there is a congestion in the heart, there is a congestion in the thoracic duct. And as I already mentioned that when there is congestion, then it causes the reflux of the lymphatic system, and it may leak in the collateral pathway or somewhere that has opening. Look at this microscopic view of the lymphatic vessel. You can see it can contract and it has valve. So when it contracts, it will push the lymphatic vessel, lymph to drain in just one direction, that controlled by the valve opening. So what is the problem? When the valve has incompetence, or when the absence of the valve, or when the lymphangium fails to contract, it will cause the congestion of the lymphatic that we can see in the primary lymphedema. So in the patient with the primary lymphedema, you may get from the mutation of some genes that control the development of the lymphatic valves or control the lymphangium, smooth muscle around the lymphatic vessels. So when there is the lymphedema, from this diagram you cannot, when you do the lymphangiography, you cannot see, or lymphoscintigraphy, you cannot see the central image pathway, but instead you can see something that's called dermal backflow. The dermal backflow is the collaterals of the lymphatic system in the subcutaneous or dermis at the upstream of the obstruction. And the treatment of the lymphedema is not the role of the IR yet, usually from the compressive therapy like this or some kind of the complex operation. And when the lymphatic flows from the limbs into the pericavity, it will from the right and left lumbar trunk and join into the systemic line and up to the thoracic duct. So at that time, as I already mentioned, the fluid is non-chyle, it's just the interstitial fluid. But the chyle comes from the intestine. So as you know, that when we eat fat, the fat will digest into the fatty acid, and long-chain fatty acid will drain via the chylomicron into the mesenteric lymphatic system. So the treatment of the patient with the chylous leakage, the doctor will order the patient not to have fat in the food, or if there is small amount of the fat in the food, they just would like the fat to be just small or medium chain only, because the small or medium chain fatty acid will drain into the portal system, not the lymphatic system. Another one is the liver lymphatic system that has a supercell in part of system. The superficial will drain to the thoracic duct, but the deep system will drain around the portal system into the cistern chyli. As you already know, the liver produces albumin, so the lymphatic from the liver has a lot of the protein in the component. So I want to address again the chyli start from the mesenteric system. So in the patient with the Fontan, after Fontan, as I already mentioned, that the SVC and IVC connect directly to the pulmonary artery without heart. So in the long run, it will cause a congestion. So it's congestion to the thoracic duct, and also they cause a liver congestion. And liver can sweat like this. So from the laparoscopic view, you can see some of the droplets at the liver surface that contains protein-rich amount of lymphatic at the liver surface. It's called wrapping liver. And it also congests and through the central system and flow backwardly into the mesenteric system and cause protein leakage because that kind of high protein-rich fluid will leak into the bowel. For example, in this case, after Fontan operation, the patient presented with protein-losing enteropathy. So we just puncture around to the tissue around the portal vein and inject the contrast. We can demonstrate the tiny channel of the lymphatic channel. As you can see here, there's a contrast leakage into the duodenum, and finally we do the fluid embolization and patient doing well. After that, after the cistern chyli, the thoracic duct will go and drain into the tubulo-subclavian junction. And the amount is of the lymphatic through the thoracic duct maybe 1 or 2 liters per day. So I would like to address about the callus effusion. Before I understand the callus effusion, I'd like to mention that normally the pleural effusion produces maybe up to 30 cc per hour. And where does the fluid goes? It will go through the small holes or small opening of lymphatic channels at the parietal pleura. That's called the pleural stoma, which are also distributed along the black dots here. Actually, this area is the similar of the area of the pleural plaque that you saw in the patient with asbestos-related pleural disease. So this kind of the pleural stoma are usually more densely at the corridor and around near the paravertebral area. This is the mouse model that they inject dye into the normal thoracic duct, but when there is the obstruction, that you can see that the dye will leak through the pleural stoma into the pleural space. As you can see here in this patient with the callus effusion, you can see the lipiodal leakage. Distribution of that lipiodal is the same as the area of the scheme of the pleural stoma, as I already shown to you. And there is a special kind of the pulmonary lymphatic perfusion syndrome that can be found in the post-Fontan procedure. And this kind of patient, the lymphatic will leak into bronchus and form cast. You can see the cast like this. It's called plastic bronchitis. And also, I already mentioned the callus effusion from the congested thoracic duct. So one of the ideas to treat this kind of leakage, they try to block the thoracic duct, and it's called the thoracic duct embolization. However, and it acts like the traffic in Bangkok. So when we block this one, it will congest and go somewhere else. So if there is another leakage, it will go to another leakage. And when you perform the lymphatic intervention in the patient with post-Fontan, the one thing you have to aware is the veno-venous collateral. What is the veno-venous collateral? It's the collateral connect between the systemic vein directly into the pulmonary vein. So it means that the one drop of the lipiodal will go into the pulmonary vein cause stroke. So you have to be aware of that. And the veno-venous collateral can be found in the SVC obstruction also, as in this case. So in this case, I will show you the veno-venous collateral from the left innovated vein to the coronary sinus. And before we do the lymphangiography in this patient, we embolize that venous collateral before and then do the lymphangiography. And there is a surgical approach. Someone think it may be holy grail of the post-contact patient because they decompress the left innominate vein into the heart. It called the procedure as the innominate turn down. So it will decompress the thoracic duct, it will improve the lymphatic drainage. So in my conclusion of my talk, if the patient presented with high protein fluid leakage, like the protein losing enteropathy or post-operative liver nephropathy, you may thinking about the liver lymphatic intervention to embolize that. But if the patient presented with high leakage, you may think about the thoracic duct embolization or embolization of the corresponding lymphatic area, the system or area. For example, in the patient with chylosasitis, you may think about the mesenteric system, or chyluria, you may think about the interstitial lymphatic system around the rim of chyla. But for the lymphedema, we still don't have the role of the interventional radiology yet now. So thank you for